In our society, we've been almost like socialized and trained to just kind of move on, to brush it aside and move on. Almost like, part of our culture has been, you live your life, I live mine.
There's a way that we think about mental health awareness as like, I noticed that they're struggling a little bit. We have to do more than notice. You have to say something. Well, hello, everyone. Welcome back to another episode of the Dr. Drew Ramsey podcast. I, again, am thrilled to be here with you, especially as we have a number of episodes under our belt. And I just want to thank everybody for all the feedback, all of the engagement, to thank the production team. Keep those comments coming. We really appreciate it as we're working and striving to get things better. We're here with our new AV setup. We have an important conversation today and a hard conversation. I thought maybe I should ask everybody, take this one maybe sitting down where you've created a little space. We're going to be talking about suicide today. And most importantly, we're going to be talking about suicide prevention. Now, as a psychiatrist, this is something I talk about a fair amount, almost every day sometimes. But for a lot of people, suicide is such a powerful and painful subject that we don't talk enough about it. And so my hope today is, even though it's a somber conversation, that you're going to get a lot of very high yield information on how to think about suicide in new ways, how to prevent suicide, how to deal with those symptoms if you have them or if a loved one have them. And we have such a wonderful guest, Dr. Christine Moutier. Dr. Moutier, she serves as the Chief Medical Officer for the American Foundation of Suicide Prevention. And this is, and she knows the impact of suicide firsthand. This organization is really one of the international leaders at the forefront, making sure that we're disseminating good science and that we're saving lives. Dr. Moutier, Christine, has dedicated herself to fighting the leading cause of death. And in some populations, this is the leading cause of death. And for the past decade, as CMO of the American Foundation for Suicide Prevention, Dr. Moutier has been leading a nationwide movement fueled by science and also fueled by grassroots efforts to reduce suicide. So Dr. Moutier, Christine, thank you so much for joining us. It's a treat to have you. I look forward to, even though it's a heavy topic, talking about it with you, because I don't know how to say that. I like talking about suicide with you because you have a lot of ideas that are new, that are fresh, that get me thinking about it in new ways. So thank you and welcome to the podcast.
Thanks so much, Drew. It's always a pleasure being on with you, and just love the conversation and also love the engagement of your community. So thank you to everyone who's tuning in.
Well, thank you so much for saying that. It's a great community, and I think increasingly we have a large community thinking about mental health, thinking about suicide prevention. So let's just start really with the first question. Can we prevent suicide, Christine? Is it possible?
It is possible. And the way that I want everyone to think about it is, it's not an issue that in every instance necessarily can be prevented. So if you are a loss survivor and you've been through that road of, the what ifs and had I known, and what would have happened if, just know that suicide is a complex health outcome. And so we can do far, far better as a nation than we have been to date. And I think things are changing, and we'll talk about some of the reasons that I'm actually very hopeful about what's coming in the future. But when you look at other leading causes of death to other complex health outcomes, what we know is that if you apply the public health model in full, meaning you invest in the research, the science, programs, the development of treatment and education for everyone in the entire community. And then, of course, with people with specific roles like healthcare professionals, teachers, first responders, that they have some extra training. Those advances that were applied to HIV/AIDS, cancer, and other leading causes of death have led to reductions in mortality. And there's no question in my mind that we can do the same thing for suicide. And we're, as a nation, kind of like getting ready to do that, I would say. And there's some really like hopeful signs again. But at an individual or a family level, there are things that we all should know and we can be doing. But I need everyone to just sort of understand that when we say suicide prevention, we mean that we can do better. we can save lives, but that doesn't mean every instance is preventable.
Reminds me a little bit of how we think of heart disease now, that we put in all this effort. We all know, starting at 25, 30, there are things to do to take care of our heart. But we also know we're not going to prevent every heart attack. But we still really put in incredible effort. And I also really appreciate your point, Christine, about when we work with families who are survivors of a suicide within or individuals within their community, that there's always this haunting question of what could I have done? What could we have done? And I think to really appreciate, as you say, that there are instances where really, there aren't clear things that could have been done for prevention. That shouldn't stop us from really trying and understanding in a public health way and an individual way what to do. To that effort, Christine, can you tell us about the American Foundation for Suicide Prevention, about your mission and your work and what you all are up to?
Absolutely. So the American Foundation for Suicide Prevention, or AFSP, we've been around for about almost going on 40 years. And our mission is to save lives and bring hope to those affected by suicide. And we actually know that that's most of us in the community who either know someone who has struggled, we've struggled ourselves, or we've lost someone to suicide. There's a whole continuum of experiences and the ways that suicide touches people's lives. At AFSP, we were founded by families who had lost loved ones to suicide and scientists who were beginning to study the reasons that risk gets raised for some people, and also how to prevent suicide. And so it's that combination of real people and families and science right from the beginning that we've now grown into an organization that is the largest one in the US. And we say leading the fight against suicide. And we do that by being the leading private funder of all suicide research on the global level, by having a nationwide network of chapters who are comprised of tens of thousands of people and families who've all been touched by suicide, mostly personally, in some cases professionally, and for people like myself in both ways. And so there's a passion to create change that then applies the science to say what actually has been proven to reduce suicide risk, as well as to help those who've been touched by suicide to heal. And so, that's the interesting thing about suicide prevention. There are many campaigns and efforts, but if they're not impactful and if not evidence-based, then at least culturally relevant and competent. And because suicide does have the potential for contagion, the issue of not doing harm also comes to bear. So it's a really incredible work to be a part of. I've been the chief medical officer at AFSP for more than 10 years now. And I was in academic medicine before that. And I really feel blessed and like it's an incredible privilege as well as responsibility to work on this issue with so many others in a way that is unique and different. It's not just applying, clinical treatment. It's not just doing work in schools. It's the entire public health model funneled into the effort in a very strategic and sustained way.
Wow. Well, 10 years of effort has led to one thing that is so exciting. For the first time ever, we have a suicide hotline, 988. And that must have been such a big part of the last decade of your work. One of the reasons I'm so excited to have you on is we see these huge shifts like that. In any phone in America, dial 988, you're going to talk to someone who is qualified to help you. That is amazing, amazing progress. And that in some ways is you and your team's effort and your organization's effort. So thank you for that. Can you tell, what is 988 and what happens when I call?
Okay, yeah. So it is the nation's crisis and suicide lifeline. And it did have a new level of federal funding and appropriation and a whole system that's developing around it, and got the 3-digit number a couple of summers ago, 988. It had long prior to that been the National Suicide Lifeline, but it had a long 800 number that no one could remember. And so putting it on par with 911 for physical health emergencies, 988 is I think, a much more easy to remember number. And so if you call it, and by the way, you can call 988 or text or chat. All three ways are fine. You can be calling because you're the person in distress yourself, or you can be calling because you're trying to help a loved one or a friend through a tough time. And then you, as the helping person, can receive guidance. And you will, just like you said, Drew, you'll be met by a real person. In most cases, a mental health licensed person, but in other parts of the country, they do train volunteers. But in any case, a highly trained individual who will help you and provide guidance as well as local resources for next steps, because their primary role that they're playing is to help the individual in the kind of hot moment of an acute crisis and to allow them to come to a place that is calm and centered and re-engaged with more healthy coping strategies and as well as resources. But of course, we know that these issues are very complicated. And so longer term follow-up may be a really good idea for many people. But it is, I would say, in the public health model of suicide prevention, it's kind of at the, we call it the most downstream, or kind of the top of the pyramid of the public health pyramid, in that it's at the moment of crisis. So when people are at risk. Now, actually, but I do want people to know, you don't have to only call it if you are feeling suicidal. You can call it because you're just not sure what to do about the fact that you're having a hard time getting yourself back in shape, with mental health, with your mood, with anxiety, trauma, substance use, any of those things, eating disordered behaviors, any of those can be reasons that you call. You do not have to have, suicidal thoughts or be in crisis. Because I think some people, might not.
I didn't know that. I had that wrong, and I think it's important for everybody to listen to hear that. Because I like you're calling it a lifeline.
Mm-hmm.
I don't have to be suicidal to call. I can be struggling with my mental health in a variety of ways. I don't necessarily need to be in crisis. I, for example, could have a family member who is having a mental health problem or crisis or has been suicidal, and I want to make sure that I'm doing the latest science-based kind of interventions and conversation. That's amazing. I had no idea. What an incredible resource. You all must have worked incredibly hard along with a number of organizations to create, that kind of map of, calling from anywhere in the country and kind of knowing, I don't know, like who to call.
Yes. And just to be clear, AFSP doesn't run 988. We're more, the way we served was as an advocate. We were a very loud voice on the Hill, and now actually increasingly at every one of the state levels, because at this point we have the federal law passed and the funding set from a national standpoint, but a lot does rest on the shoulders of the state legislatures to be doing things like passing a telecoms fee that would allow it to be sustained in their local region, and then to build out the resources that aren't just about the acute crisis moment, but let's say a mobile crisis team or mental health centers or peer support, rather than go to the ER or nothing at all. We really need to have a full-fledged mental health system. And that's part of the 988 plan, even though 988 is kind of viewed as that crisis or lifeline number. It really is actually much more than that. When you think about, do we have a place to go if we, whatever it is, break our leg or feel like, our hypertension or some physical health condition is getting worse? I mean, access to physical health care is an issue too, but access to mental health care is, we are way behind. And so 988, part of its purpose is to build a more robust, not just crisis response, but the full mental health services continuum.
It's fascinating. It's almost creating a national referral database in a lot of ways, and building in, it sounds like, a lot of policy to keep that funded and sustained. Christine, I feel like we're getting into policy, and we're going to get to a lot of tips and kind of clinical tips. Those are what's really important, and also I think personal tips But Christine, you mentioned something I don't want to skip over it, that you're an individual who has come to suicide prevention for both professional and personal reasons. And I'm also one of those individuals. And I wonder if you would share with everyone a little bit about what brought you to this work.
Absolutely. I'm really more than happy to talk about it because I myself am trying to live stigma free, and I really believe in this. So I am, really kind of an open book. So my own story was that I had my own mental health struggles and lived experience while I was a medical student is really when it came to a head. And I was fortunate enough to be encouraged not to drop out of med school like I had been planning to do. I really thought this is it. I'm not fit to be here, and tried to drop out. I ended up taking a year off, got treatment for the first time. That was therapy that changed my life. And I began to really start to understand, as a result of having that help through the therapy, that helped me make so many discoveries about the way that I was operating unbeknownst to myself, with all these sort of unspoken, unwritten, really harsh rules, very punitive towards myself. And the idea that I really began to embrace is that as a human being, like every other human being on the planet, and with everyone else, I feel naturally so much grace and love and just support for, that I deserve that for myself, and that I could make choices that were good for me. And so even the choice, for example, to go back to medical school, which obviously is an extreme privilege to have that opportunity, but for me in that moment, it was a very scary one. But to allow myself to make that choice, to just give it a try, to see again if it could be for me. And, so fast forward, I stayed in medical school. I finished. I began my psychiatry training. This was all at UC San Diego. And then during my years of residency, there was a medical student who took his life. And I had worked with him several months prior, and it affected me actually very much, that I had that natural reaction. Even though we weren't super close, we had had a little bit of social contact since the psychiatry rotation where I'd worked with him. But I went through all of that sort of, or some, I shouldn't say, people who lose family members, it is life-changing. But that sense of numbness, really almost depersonalization, kind of feeling like I'm not sure what's happening, and kind of almost watching yourself from the outside. And I went through all of the what ifs, what did I miss? And it's certainly, I think, in addition to my own mental health previous experiences, that experience of suicide loss, living in medical culture at the time, in academic medicine, where, like many occupations or learning environments, it doesn't feel like a supportive environment where you can be authentic about what you're going through. And so that was really the start. And fast forward later, I was on the faculty at UCSD. I'd become a dean of the very same office that the person who had, encouraged me to stay in medical school. And now it was my job to be overseeing aspects of policy and curriculum and culture. And this really had become sort of my secret mission, to change culture around mental health and, getting our needs met as human beings during medical training. And there were a number of physicians who died by suicide at UCSD over those years. And it was too many, to the point that my boss's boss's boss became ready to do something about it. And so that was a real moment of opportunity where I got asked to get to the bottom of this, were his words, which meant, how many people have died? Does suicide of an individual have anything to do with the environment of the person around them? How much can we influence a person's resilience or their risk? And so anyway, that was the start of it. And I began a suicide prevention program at UCSD with my mentor, Sid Zissuk. That program is still going strong. And I believe it has saved probably a number of lives of physicians, nurses, and trainees at UCSD in these 16 years since that program started. And then through those years, I began volunteering for the American Foundation for Suicide Prevention. And that's how, when they were looking for their next chief medical officer 10 or 11 years ago, it was, it's kind of meant to be. They found me and moved from San Diego to New Jersey.
That it's such an idea to change a culture, especially when we think about maybe the culture within a family in terms of how we talk about mental health and we talk about suicide, to the culture of a profession like medicine, where we know that physicians, I think, still along with farmers, I hear, but generally physicians are the top, if not one of the top professional categories that die by suicide, which is, such a, in some ways, such a tragic conundrum, right in the midst of the very people who could help you. I felt that when my own mental health is in a bad spot, how awful it is to know the exact expert, like have their number, who would do anything to help you, but not in some ways feel like you deserve to or should or are too ashamed to make that call. And so Christine, thank you so much for sharing that. You talked about an awareness of a need for, I call it a type of self-compassion or self-love, and having a kind of maybe harsh or critical internal world prior to that, maybe therapeutic observation. And I think so many people listening have a hard time with that. We have a lot of critical voices, but we have a hard time having compassion for ourselves. Are there ways that you are able to kind of promote that or sustain self-compassion that you could share with us?
Sure, because I like the way you put it. It is not a one and done, although it was a big turning point in my life in my early 20s. Here I am now, 30 some years later, and it's still a journey. It's still very dynamic. It ebbs and flows with all the stressors of life. Just, we're all so human in living with, our plate of responsibilities, stressors, family members, health issues, any number of things. So for me, this might be a little extra, but because I was a dean, I was developing curriculum around these topics. I do feel like for myself, it helps me to see it as actually a responsibility, that if I don't find ways to keep that, I view it almost like a reservoir inside myself and inside of all of us, from which we're constantly drawing on for coping and for resilience and for maintaining, calm in the face of difficulties and interpersonal conflict and whatnot. And so seeing it that way then helped me and continues to help me to build in a practice that, if not daily, is sort of has a regular cadence where certain things are scheduled in for me. So for me, and I think it's up to each of us to figure out what those things are. For me, those things look like a daily practice of yoga or Pilates. It's having time set aside to connect with my partner. He's somebody who knows me well. And when we're in a situation where, weeks or months are going by where we just don't make that time for whatever, lots of reasons that can happen, it starts to wear on not only your relationship, but, all sorts of just feelings of resentment and cynicism and things start to naturally creep in. I almost view it as in the field of physics, like entropy, it's just going to go a certain way and it's not a good way unless we apply some sort of intentional practices.
It's an entropy, I think, of process, right? It exists in marriage, but it exists in kind of all of our relationships, where we go from this kind of active, dynamic, fun, spontaneous, often very sensing, kind of intimate partnership and communication that's in process. So I love this idea of, losing entropy. Mm-hmm. You can, when you're a therapist, you really kind of can feel it session to session sometimes, where you have this momentum and kind of flow in the conversation. The session just flies by. And I think the same thing happens in all of us. And I love how you talk about the maintenance of it. Because so often, especially long-term relationships, it becomes kind of a trope of like a date night. And date night is definitely not my favorite way of connecting. I like coffee in the bed in the morning. As much I'd take that 9 times out of 10 over date night. And so really, for everybody listening, finding that way, it doesn't have to be your partner, but for sure first. You hear like right after self and movement for Christine, it's maintaining the partnership that is so helpful because it's someone who knows her. I just think that's such great advice for all of us to hear.
Yeah, and leaning on others too. I learned that processing the hard stuff, even if, don't be so hard on ourselves. Like the hard stuff are those moments where we're not sure what just happened in that meeting and we're left with kind of a weird, uncertain feeling. And having whoever it is in your work life or in your personal life that you trust and where there's just some regularity to it. So this could be like, when you formalize it, it can look like a peer process group or a mentoring relationship, a buddy system, where the whole idea of it is you just get together on a regular basis and you give each other permission to talk about the real stuff. And I think, all those stereotypes are so wrong. Like, people in the most tough of professions, the most kind of stoic cultures, occupations that you think are just, all on strength and self-reliance. You give people the opportunity to share what's going on just under the surface. And if it's a safe environment, most people will. And we do that for good. These are not, pointless gripe sessions. These are extremely helpful ways that we sort through and we organize our brain and our coping around what it was, what happened, and just sometimes framing it, let alone like getting into solutions and actions that we can do. So I guess, and that gets into setting those ground rules for each other that we don't have to solve each other's problems when we get into this. It's purely active listening. It's really that kind of peer support, just processing through. And then, of course, I am also a huge fan of therapy for myself, as well as, being a psychiatrist. And so there are times, and this might be one of those times in my life, actually, that I feel like I'm coming into where it might be time to, to find a therapist again.
Yeah, that's I think something I wouldn't say it would surprise people, right? But I think when you're sort of set in a wonderful job, you've changed national policy and saved countless lives. You have a strong and active partnership that you have mindfulness around to maintain and take care of. I love hearing that it's a time where you're also thinking about getting back into therapy, because just as we don't want 988 to just be a crisis line, it's a lifeline. And we want therapy, I think, to be destigmatized as not something that's just when we have, a DSM-5 TR diagnosable mental illness, that it's a place for us to set goals, achieve them. And as you said, that great example you give of process. I love this idea that you had around when we get into groups, be really aware that we're not there necessarily to fix things. We're there to be in process, to put words to things, to put framework, to maybe have a shared experience. And so often we really miss that. I particularly hear it from wives who are like, why's my husband always wanting to fix it? Why don't you just like sit with me? Even if you're a therapist husband, it's true. It's like we are, it's I want to do something. It's sort of like, don't just do something. Just sit there, listen, be present, be active.
Yeah. It is remarkable because no matter how you're trained, and most of us are not trained actually in just active listening skills. And in every relationship, it turns out to be pretty important.
Well, let's turn a little bit to suicide prevention, some of those communication tips, because you've helped me both in my personal life, that when I have terrible feelings, you described it last time we spoke, that you have to think about them like waves. And that really spoke to me as a bad surfer, because waves always come in sets of three. You're always a little anxious about them. There's always some big wave out there lurking. But something about being in the ocean is everyone is just constantly changing. That's what makes it almost so captivating, right? You think it's still 1 second, then it's raging, and that really helps. Like that this acute, really bad feeling is going to dissipate. But can you share this with some of, let's say, the fundamentals, of suicide prevention in your mind that you wish all of us knew?
Okay, sure. Well, I'll start with, maybe this is a little nerdy, but I think it really helps to understand that the brain actually can't hold a state of tunnel vision crisis for a long period of time. And so it does help me to know, just like you're saying, Drew, that if you're feeling something really intense, if you can just experience it, it physiologically is going to dissipate. It's just, there's studies that show that that type of brain functioning where you're in more of a fight or flight mode and the frontal lobe and cortical areas are kind of shutting down. So we're really functioning in the primitive part of our brain and feeling a whole lot of distress. And it makes us want to impulsively react oftentimes.
Makes us want to be primitive.
Yeah, exactly. I mean, there's anger, there's sadness, there's desperation, there's a lot of feelings that can really, when you're feeling it, it's a force. I mean, it's hard. And literally what's physiologically what's happening in the brain is those higher cortical areas are just quiet because the inner part is raging. So you just, I've learned for myself that just a couple things that we can do. Like if it's happening when you're with your partner and you're in an argument, you can do things like, let's get outside and take a walk. Because when we walk and talk, things start to settle down. And I actually even think there's something that's sort of EMDR-esque about the bilateral movement of walking and processing through a hard thing.
Break that down just a little bit for us. EMDR, what are you talking about?
Yeah, so EMDR is that form of therapy for trauma, eye movement desensitization. I forget what the R stands for.
Desensitization EMDR. Response, I think.
There you go. Okay. And I've had EMDR myself, and I've also, delivered EMDR. And it's an incredibly effective treatment, and it's usually a pretty short-term treatment, actually, for helping almost like file away highly charged memories that are traumatizing into the part of the brain where it sits as a plain memory instead of as a charged up one.
I like it. It's like hurting.
Yeah. And so this is like totally unscientific, but when you're walking, it's a bilateral movement. And that's, what EMDR uses is eye movement or this little tactile sensory mechanism that goes zip, 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 zip back and forth bilaterally. And that's thought to be a part of what's happening in the brain. You're processing and both sides of your brain are being activated. And so anyway, I'm a psychiatrist, but this is like my lay feeling about walking and especially walking and talking. But I also know people who will just walk and part of their, daily activity. And they'll find that the things that are charged up and kind of chaotic in their mind will have a way of sort of getting settled down and into more of a solution or a clarity. So it's just interesting. So anyway, back to, what we were starting with, which was that what we can do, a very practical thing for ourselves. And also if you're sitting with a loved one or you're worried about somebody who is clearly not themselves, they're going through something. It might be showing up as agitation, anxiety, withdrawal, depression. They may have expressed hopelessness. And there is a good chance, by the way, that they could be having suicidal thoughts, because when those experiences are there, it's a very human response. And having suicidal thoughts doesn't mean they're about to act on them. But it is a very good idea to know that there's, we're complex. So there's a part of their being, even if they're not showing it to you, that knows that they're suffering. And even if they've been reluctant, don't assume that you can't have this conversation. In fact, I would say don't assume that at all.
It sounds like, and maybe change a little setting. Get them for a walk. Invite them for a hike. Take them to let's get you outside and go for a walk. And I also hear you telling us be brave. That if you hear hopelessness, I would throw in sleeplessness. You see more substance use. You hear some of those classic signs, and you let me know which one of these are wrong. But the ones that I generally look for are things like giving things away, talking about the world without them. Mm-hmm. Some really concerning ones I've heard over the years: people making jokes about life insurance, policies. But tell us, what are some of the most concerning signs that you hear about and you see?
Well, I really take it to a much more upstream place because I've lived this so much with patients, with family members, when I was a dean, with medical students and colleagues, that our behavior patterns are incredibly, we think of ourselves as autonomous individuals, and of course we have our free will, but our behavior patterns are actually in a pretty narrow range. And so when you notice that their behavior starts to shift out of that normal range, and that can look like certainly those things you mentioned, but it can also look much more subtle. It can be change in the words that they're using that hint at feeling desperate, hopeless, like they feel trapped, or like they feel like they're a burden to others. And they rarely will say it outright like that.
But you just kind of hear it, you kind of sense it in their process. Wow, something shifted. This person is sounding more hopeless. They're kind of acting like they're a burden, or they're talking about maybe, I'm so sorry. I know this would be better without me around, kind of thing, or even maybe more subtle than that.
Yeah, even more subtle than that. So, more of a cryptic from the side, oblique comments that you think, what was that? That was uncharacteristic. We, in our society, we've been almost like socialized and trained to just kind of move on, to brush it aside and move on. Almost like, part of our culture has been, you live your life, I live mine.
There's a way that we think about mental health awareness is like, I noticed that they're struggling a little bit. I'm like, I don't, and we have to do more than notice. You have to say something.
Totally. And just to encourage everyone how this works and how it can work for you, we have this ad campaign called Seize the Awkward for young people, 16 to 24-year-olds. In our research with focus groups of young people, they said they all know when their peers are struggling mightily. They know it. They're with them enough to recognize without them even having to bring it up, through words, but just noticing those behaviors and changes that someone is struggling. But what they didn't know was how to breach through. It's called Seize the Awkward because it felt awkward to them to kind of dive in and have the caring conversation. What words do you use? How do you not, increase their risk or make it go bad, insult them? And so there's all kinds of tools around the Seize the Awkward campaign. We have another one for adults now called Talk Away the Dark that has the same for adults. But I wanted to tell you about that because what the young people said to us is they take their roles, almost their responsibility as a friend, really seriously. And so it was distressing to them to not feel equipped to know what to do. And, I think that kind of attitude where we care about each other. We do. We're social creatures and we're in relationships with lots of people, not just in our family, but our community, our workplace, our faith community, wherever it is. And we can have conversations and here's what I would say is when you express caring concern and you do so non-judgmentally, and like you're saying, maybe it's inviting them for coffee or a walk or a hike, whatever, the way you can open it up is to say, thank you so much for setting this time aside and agreeing to meet with me. I so value this. And I reached out to you because I care about you so much. And I want to find out what's going on in your life. I noticed that you don't really seem yourself. It's okay to tell them that. It's okay to say, I noticed that when you came into whatever it is to work, last week, you just didn't have the same, demeanor. You didn't look yourself. And there's no judgment here. I'm coming to you because I want to learn how I can support you better. So it's in a way you're expressing caring concern, no judgment. And you're saying that the entire purpose of this conversation is so I can learn so that if there is any way, that in my, whatever the relationship is with you, that I can support you better. And you just let it be super open like that. If the person chooses to share, then that's when you start listening Again, active listening skills, you don't have to jump in and say anything at first. You can just be taking it slowly and listening for because they'll always describe the circumstances of their life. It's about work, relationship, finances, breakup, car.
We should expect this. We're going to hear we call this, it's a rationalization. It's just, and then we get a long list of all of the stressors.
Right. But the stressors are real, and those are the circumstances that make up our kind of life, the external guideposts of our life. But what you're looking for is the way that they're talking about it, their tone of voice, their perspective on all of that. And again, if they sound like they're feeling just flattened out, overwhelmed, like there's no recourse, they've tried things and they feel like everything's futile. There's no more hope, or they've run out of ways to cope. Anything that says that or hints around at that, that's my cue to say, wow, thank you so much for sharing that with me. And again, you can always say, I want to hear more about that. Like getting them to talk even more can be really helpful and actually therapeutic for the person to not be judged and to be sharing. And then beyond that, when those signals are there that they might be having thoughts of suicide, I just come right out and I ask. And the way I ask it is I say, when you talk about this circumstance, and I'll actually use the words they used, it makes me wonder if you're having thoughts of ending your life. So I'm kind of even just sort of making a statement of observation and let them respond to that. And if they say, yeah, that does happen on occasion, you can certainly be curious. You can say, tell me more about that. You can also say, wow, that must be really tough. And I want to be here for you. And I want to help you get the help that you need. So you do need to know in the helping role, even though I'm a psychiatrist, if I'm doing this with a friend or a family member, I'm not their psychiatrist. I'm their mother or their spouse or their coworker. And so I'm also doing the same thing. I'm saying, what do you think about getting some professional help? Because it sounds like once you're having thoughts of ending your life, it's gotten to a place where it sounds to me like there could be something to address from a clinical and professional standpoint. And so that's oftentimes then helping them figure out how to do that can be, a next step.
Thanks so much for that, Christine. It also sounds like a moment that you identified for us is when people maybe disclose some thoughts. And for us not to feel a pressured notion of having to ask a bunch of questions, come up with a safety plan, find the right therapist, but in some ways to really anticipate that that's a wonderful moment because someone has shared it. And that's the first step to really de-escalating whatever risk is there. Because a lot of times we have suicidal thoughts and, there isn't an extreme risk. We don't have a plan. We're really having horrible thoughts. Or maybe we do have a plan, but there isn't, as much risk. But the minute you're talking about it with someone, I think it's a de-escalating risk. And then to let it, so kind of, I don't want to say like air out, I don't want to do nothing with it, but to give it space, because I think a lot of times people are so ashamed of having suicidal thoughts, and they're sure the minute especially with us, the minute they tell us, it's like, the sirens are going to go off and they're going off to the ER. And that's so rarely the case, because if we're talking about it, we're mitigating risk.
That's right. And the trend in suicide prevention science and practice is to not have a knee-jerk reflex off to the ER. Even for pediatricians, the training now, and not just pediatricians, but family medicine, frontline health professionals, it's to try to keep people in their normal course of life, but as outpatients, getting the help that they need. That is viewed as the far more person-centered, culturally appropriate and resource responsible way. And frankly, now we have tools. Also, the science has provided us with safety planning and.
Can you tell us a little bit about the science based tools in the sense? I think people are sometimes to be surprised, that there are things such as suicidologists, people who study suicide and suicide prevention and do research on this.
Yeah. I think that's a new modern, phenomenon of the fact that we started to understand the brain more. But suicide science involves not just neurology, but also psychology and cognitive scientists and sociologists, cultural experts. It's a very multidisciplinary, really exciting world. And many young researchers are coming in with passion and being mentored by, more senior suicide experts and researchers. So yes, there's something called the safety plan intervention, and that's a development that came out of this field. It was doctors Barbara Stanley and Greg Brown who developed it and found that what the safety plan does is it allows the person to work with usually a therapist or a clinician, but it is now being used even, with guidance counselors and with peer mentors, although that's a little less studied. But I'm actually feeling like if people are doing it well, it can be done in a variety of ways and settings. But basically what it does is it allows the person to kind of go through a process of identifying what are my personal and unique triggers for feeling worse and having suicidal thoughts, and what are my personal and unique ways to effectively feel better. And so Barbara and Greg will call them distractors. So for people who the suicidal thoughts are just so distressing and kind of won't go away, then listening to music or taking a walk or calling a certain friend can be ways that you kind of jumpstart your brain out of that mode. I've always thought of those coping techniques as much more than distractors, actually, because it's sort of training your brain that there's a different way to feel and think and cope. And the more that people use the safety plan and actually practice it, the more effective it is. And so it can be a tool that's used in ongoing therapy or while a person is getting substance use treatment or counseling in a variety of settings. And it's now been researched and found to actually reduce the likelihood of later suicidal behavior or attempts.
And so it sounds like we should acknowledge that if we have these thoughts or feelings or other people do that, one, they happen for unique reasons for all of us. Maybe you had a set of traumas that people don't know about that, either extreme or very subtle, that lead to these sets of feelings. And I like the idea of not just distancing ourselves from them, but understanding maybe there is something in them for us. I think also sometimes people have suicidal thoughts in such states of clinical depression, that there isn't that kind of meaning in some ways, that circumstances cause it, but the kind of answer is very suicidal when individuals maybe are in the state of a major depressive episode.
It can also be that, a bunch of things. Suicidal thoughts are actually so commonplace in the general population that they don't have to be driven, just like you're kind of implying. They don't have to be only associated with a clinical, severe episode of depression or PTSD.
People just have them. People just have suicidal thoughts. I'm walking down the street. I should be aware that a lot of people around me maybe are also just having suicidal thoughts, who aren't depressed or not struggling with substance. The brain just has them.
Yep. And they're when you feel in a bind, the brain is sorting through all different sorts of different coping strategies, and it can come to mind as a way to escape the current circumstance of pain, desperation, physical pain, a number of things. Suicidal behavior, though, and certainly suicide deaths, are much more closely linked with the risk factor of a mental health condition among usually several, more than 7 to 10 in psychological autopsy studies that is found. So I guess what I was thinking of when you said that is that a person could in fact be in the throes of a severe depression, and it could be that their set of unique pathway of this thing happens, I feel not good enough, that triggers that feeling that then I'm no good, there's no future for me. So there can be a sequence of sort of events and cognitive beliefs that, again, cognitive behavioral therapy is so effective both for depression and anxiety, but also for suicidal thoughts. And CBT, cognitive behavioral therapy, was actually studied and then specifically developed out further by Aaron Beck and, again, Greg Brown, who developed a form of CBT for people with suicidal thoughts that doesn't only get at the depressed mood or the anxiety, but also really hones in on that pathway to suicidal thoughts and teaches the person actually to sort of retrain their brain in a way.
Yeah, it's really a lot of folks listening, I think, no, but CBT is cognitive behavioral therapy. And what people like about cognitive behavioral therapies is they're manualized. And they're, unlike a lot of therapies, therapies I love, right? We're going to talk all about your past and your dreams and our relationship and all that stuff. CBT is really very focused on your thoughts, feelings, and behaviors. And so it allows people to kind of map out the relationship between these things in a really effective and helpful, concrete way. There's a CBT for insomnia. Just try and really shift and identify then shift maladaptive thinking patterns. Catastrophization, for example, is one of them, right? No one in the world likes me at all. You say, I'm going to challenge that thought a little bit. And, there's some people here in the world that like me and love me. I might not feel it right now, and so that's a really great resource and thing to think about, because a lot of times when people ponder psychotherapy or maybe being suicidal at times and you don't know what can be done about it, they're really specifically manualized research therapies and that can help you specifically with those feelings. Christine, I wanted to talk a little bit around the upstream things. I'm here in a new community in Jackson, Wyoming. We have about double the nation's suicide rate. It's a very a classic mountain community. Our clinic, Spruce Mental Health, is going to be hosting, along with Teton Youth and Family Services and the Behavioral Counseling Center here, a screening of a movie called Paradise Paradox, which is a documentary around the mental health crisis in mountain towns. The mountain towns have this, in some ways, unique set of circumstances, incredible wealth disparity and income disparity. In some ways, a lot of resources. There are a lot of therapists here, but also a culture often around drinking and some denial and stoicism, and do it yourself. And so there's a lot of suicide here. Some of the consultation and expert consultation, the community's actually been really amazing in terms of reaching out to experts to say, hey, what can we do? And Dr. Corso from DC came out and really had the community thinking, just like you are, like upstream. And so I guess this is a twofold question. In our individual lives and in our organizations, what do you mean? What can we do upstream to prevent suicide?
Okay, so at the individual level, and again, I think about the public health pyramid. So there's like, what can everyone be doing? And that's primarily education. We can be learning and applying that knowledge into our life. And that's a very personalized experience that you can actually learn how you can optimize your resilience. And I know that seems so kind of pie in the sky, but I've seen the evidence of how that works for me. And it is not a simple thing, because you do have to kind of figure it out at each phase of your life. It can change a little bit. But if you even just develop an awareness for it, and journaling is a great way to sort of start letting yourself explore the relationship between certain activities, certain foods, people in your life, and how that influences your well-being, your sense of identity, your sense of humor. All those things are, there's a relationship. We're so dynamic, the way that our body and brains are wired. So it's in a constant state of growth and change and flux. So kind of learning, I think it's a continuous learning model that I would say is about, again, a little bit of education and then a lot of kind of applying it. And I do think, again, that therapy is a tool that helps us get more mileage out of that. I can do that myself, and I'm going to get much farther along if I have a professional who I'm doing that with.
Yeah, and I also love that idea. The therapy in some ways sort of teaches a little bit of the technique and allows your brain to kind of live within the framework of a very curious, very non-judgmental process conversation. Feelings happen for reasons. They come from places. We can understand them. Sometimes we can't, but we can find strategies to build our resistance, to cope with them. And that's in therapy, but then also as you're encouraging us, you don't need to have significant mental health problems to get a lot of benefit from that process.
It's really true. I mean, and it can be, now for me in my own life, I can sense when things are shifting in a way that I'm not as resilient. It can be that my frustration tolerance is shorter. My mood can get more irritable. And believe me, I'm sure the people around me can testify to that. But developing like a self-awareness for when those things are changing. And again, it's not about judging myself. It's about something is happening. I'm human. It's okay. And there are things I can do about it.
Mm-hmm.
And the things to do are sometimes as simple as the process of kind of thinking it through, writing about it in my journal, or talking to my partner. And then I'll just make some sort of like I might go to bed a little bit earlier. I might, instead of whatever screen time, I might read, some meditations in bed before going to sleep. I might be ready with a meditation that I know has worked for insomnia in the past for me, so that I have it ready to go on my nightstand. It's little shifts like that don't seem earth shattering, but always kind of surprising to me, actually work for me. So with just like a little bit of effort, I'll notice that I just feel myself again.
I think what's surprising is we have this idea that mental health is this massive effort. We're on therapy for it's all hard. It's all working through the trauma. It's all personal secret stuff. And I think this model you're talking about is much more representative of real life mental health. That we raise our level of awareness. That doesn't actually do anything for us unless that really important step Christine tells us, right? Then we take a little action. It's not a huge action. It's going to bed earlier. It's reading some gratitude prayers. It's making sure to really one that I do. I really make sure I'm looking my kids' eyes, because I hate that feeling where it's like everything's getting too busy.
Yes.
And there's just something about it. Really, you just not like a weird dad, like stare my eyes away, but just in a like I make sure, and I really saw that. I took a little more of a reading. And I like this idea for all of us, for everyone listening, that mental health is made up of little small steps. That there maybe sometimes there are some mysteries for all of us, but these little pieces, that is the action. That is the kind of instrument of change.
Yeah, and I think we all have complications in our background, whether it's childhood experiences, whether it's racial discrimination and microaggressions. We unfortunately, most human beings don't get through unscathed, and so there are things that are really helpful to become aware of. But again, like you're saying, the awareness is a piece of it. But then even more so, it's how do we then take those steps to feel our full potential, our full selves. And it's not that we're aiming for happiness all the time. That's really not realistic. Our human emotions are on a journey, and that's just what it is. But it is the ability to notice what's happening and make that shift, to come back to, I want to be a hopeful, and a loving and a patient, kind person. I notice that I'm veering off track from that, and it doesn't feel like myself. So those are just, I think, the really, in a way, like most basic building blocks, like you're saying, of just kind of managing and optimizing resilience and mental health. I think if you're someone as an individual or in your family that has a family history of suicide, if you've had gone through the exposure or the experience of losing someone to suicide, or if there are particular things like growing up in a family with a parent with unaddressed mental illness or addiction. Those are all more significant risk factors for suicide to pay attention to. And in a way, just like we were talking about with heart disease earlier, we can apply the science to our lives to say, okay, with the heart disease, if I had 3 uncles who died of a heart attack before age 50, I generally know that means I got to do some extra things to take care of myself so that in case I inherited those vulnerabilities. It's the exact same thing for mental health and suicide prevention. We can apply that knowledge and really just gird ourselves in a way, and also do that for our family members. It's a learning journey because no one learned how to do this, in our society. It's really a new day with science informing all of this.
Christine, I realize we talk a lot about prevention, and it just struck me, I haven't really heard much around what do we do when there's a suicide. And I'm wondering for people, especially listening, who have had suicides, within their friendship or family or even organization. I think a lot of times we don't know what to do. I've had the experience clinically where my brain, like my clinical brain, keeps like engaging about like what can be done. Have they tried this? And it's really an awful, like I said, a haunting pattern. And I'm wondering what your ideas are, maybe more than tips, around when we are near a suicide or experience a suicide within our community. What should we do?
Yeah. Well, there is a lot known now that we didn't have knowledge of necessarily, at least not codified, in a systematic way. We know more about how people who experience suicide loss, how they now people are very different, so they're unique paths, but there are themes for healing, and for how that journey progresses. And we look at suicide bereavement like any form of grief, that it's not about getting to a destination of, sort of getting over it. It's a matter of kind of managing through it. It's very much about the journey. And I would say the couple of things that come to mind, since at AFSP we have this incredible community of suicide loss survivors and any number of really wonderful resources and programs. But oftentimes it's helpful for suicide loss survivors, number one, to connect with other suicide loss survivors.
It's a unique loss. I mean, as you say, it is bereavement and grief, but there is a unique quality to a loss, to suicide.
Yeah. And if you're not sure how to find a support group for suicide loss survivors, we keep, I think, the best sort of up-to-date listing of nationwide, 800 or 900 suicide loss survivor support groups on our website. So you can go to afsp.org. afsp.org to check that out.
Wonderful. And we'll link in the show notes, everybody, on my site and also on all the various platforms. So it's really easy for you to find these resources. So one is the thing after suicide, especially if we're really touched personally in a way, which of course we're going to be, but if it's very proximate to you, finding groups and survivors, suicide survivors to speak with is important. I'm sure AFSP has a lot of resources on the website. How about kind of in terms of avoiding contagion? Contagion, as I understand it, is the idea when there is a suicide, and then there are many suicides either of a similar method, which is I think one of the reasons that the current AP guidelines on style and reporting say we're not going to use the phrase commit suicide anymore. And we're not going to report a lot of details about the how, because that leads to more contagion. But are there other ways that we can prevent contagion?
Yes, if you are part of the leadership of a school or a workplace or a faith community, really any role, in a community sort of setting like that, then there's a set of guidelines for how to lead a community through the experience and the aftermath of suicide loss that is two-pronged. It's number one, to facilitate healthy grieving and for people to, to work through all of that together, because it is confusing and traumatizing. But number two, to decrease and mitigate that risk of suicide contagion. And so the communication steps that are outlined in, again, we have these guides that are put together because nobody, thankfully, has to walk through this, frequently enough to really have deep knowledge about how to do it. So there's a toolkit for schools, K-12 schools for after suicide. We have it for workplaces. We have it for medical schools and residency training programs. And we actually worked with the Veterinary Medicine Association in the U.S. to develop one for veterinarians as well. But it can be, the principles are the same. There needs to be communication that is as open and clear and kind of educating as possible. Now, if the family is not willing or ready to allow their loved one's death to be called to suicide publicly, then that preference is abided by. And so the email that would go out to the community would say, we've lost a treasured community member, student, and this tragic loss may be, affecting all of us. So you don't have to call it a suicide, but when they do allow for that, it is absolutely recommended to actually, in the announcement, to call it a suicide, and then to follow that up with the resources. And so that's the communication plan is part of it, but there's also a team that gets together probably twice a day for the first, week or two following the death to carry out the rest of the plan, which is really about looking for opportunities for debriefing, facilitated, groups, to enhance the resources, to keep the communication strong, and really importantly, to be on the lookout for individuals within the community that may have their own suicide risk sort of activated and become more vulnerable in that we're very social creatures. So it's not just anyone who can have that impact, but people who already have suicide risk factors or are struggling can have their risk for suicide elevated just by that exposure within the community. And same thing with celebrities and reporting methods.
Is part of the intervention and communication then acknowledging that, saying, hey, we've had a suicide, this is a tragic loss. We also know that many people in our community are at risk and that your risk goes up, and we are here to have this conversation to mourn and to prevent, and kind of in that very explicit notion?
Yeah, we don't actually explicitly state it. Suicide is so tricky because when you, for example, if you, in a very public way, it's one thing to talk to, a small community or one-on-one or patient, doctor to patient, but it's another thing to say, through media or social media or in a large group setting that this is a moment where suicide risk is increased.
Don't say that.
That message could signal to the suicidal person, it's
okay.
Normal,
it's okay.
Yep. So so suicide prevention has a tricky aspect to it because we want to normalize everything in the human experience, and especially help seeking and treatment. We don't want to normalize or inadvertently or accidentally say that this is a time when suicide is inevitable. And that's how some people might interpret certain things in the news. It's why we don't recommend the term epidemic of suicide, because that almost implies it's catching on like a contagion that's going wild. And that's not actually how it works. It's the contagion effect is usually in a cluster that ends up at kind of maximally with, a small group, thankfully, but that's still obviously too many and very tragic. But it's not like, a virus that can spread, to hundreds of thousands. It's not quite like that.
But it sounds like being clear that it's maybe it's a time for us all to care for our mental health, to support one another. It's a time for us all to be talking about hard feelings. It's a time for us to be grieving together and reaching out for help. Sort of giving, these are the things we should be doing, but not saying, hey, everybody, we really want to prevent contagion. That's kind of more behind the scenes in terms of explicitly what administration is trying to do. It sounds like all organizations, colleges, schools, obviously, it should make sure that they have an acute response plan in place. Because the other part I hear you telling us is that when there is an event and a loss, when there is a suicide, we have to make space and create space for our communities to work through it. And there have to be people in our communities who take the lead for that, because if not, it's just not going to happen. These are
That's
hard
exactly.
conversations. We're naturally avoidant of them. We're scared of suicide, and I think that's just a wonderful takeaway for everyone, because we're all involved in some organizations, and it's one of those things that you don't need it until you really need it. And look, if you're in an organization that has a suicide that doesn't have a lot of planning in place, AFSP is a great first stop for lots of resources, a detailed plan, and also I think a lot of individuals involved in the organization who can be of help, who have had, unfortunately, similar experiences, but with that comes a lot of wisdom and
Yeah.
ability to help.
Yeah, our chapters are in every kind of major market. We have a wonderful one in Wyoming and Montana, and so pretty much wherever you are, that AFSP chapter is just looking for your reach out and wants to get engaged and just provide you with some resources and kind of help you along the way. And our chapter folks will lean on our national team very frequently when there are situations that are really tough and need some extra. We are, again, we're in this because we're passionate and want to translate science into action in real families and communities. That's really the joy of the work that we do. So don't feel like it's don't be shy about reaching out for help. And I would also say, if you're not trained in this, do not worry. You're not taking on something that's beyond your scope of practice. You can have a local mental health clinician come alongside and be part of that postvention team, or to lead the group process and grief process. So you really can construct a plan that you can feel confident in. You're not going to have to be speaking, out of turn. And it's why we've scripted a lot of the things, because it's even for me, as experienced as I am, if I'm going to walk into a space in the acute aftermath, I'm going to just refresh my own, ground myself in the basics and be ready for that moment, because it's a very emotionally charged moment as well.
It sounds like it's really important for us to see how much Christine is saying that we're not alone. If you're sitting somewhere right now, sometime in the future, and this podcast finds you and you're feeling suicidal, you're not alone. A lot of people have these thoughts, and there's a lot of ways to get help, from formal therapy to lots and lots of support groups. So don't stay alone. Reach out. And if you're an organization, a school system, a police force that's struggling with suicide, you're not alone. We got all kinds of support, resources, brilliant scientists and researchers, and brilliant families who have struggled through this and understood over years how to make it as least painful, I guess, as possible, but also as effective in terms of dealing with grief. Christine, you're in the midst of something that's so hard. You hear about death by suicide every day. You see the numbers for all of our efforts creeping up. You see the news, just like all of us. And I was wondering if you could leave us. Is there a kind of a mental health mantra or mental fitness tip that kind of, in the moments that are challenging, keeps you going?
Yeah, I think for me, it depends on what it is that's getting under my skin. But, for me, on the issue of that, suicide rates have gone up in the last couple of years. We had a couple of really wonderful years where the rate went down for the first time in a couple of decades. But I'm part of a team, so I come back to my team and we talk about where are the opportunities. So far, for example, at the national level, We have congressional members interested in suicide. They're starting to pass more laws on suicide prevention and mental health. But as far as the actual investment, again, 988 is the first, I would call it a down payment. But when you look at the investment that's made in other leading causes of death, it is 2 or 3 orders of magnitude higher. And I believe we're going to get there. And so it's, I give that as an example of I find my sort of North Star and remind myself of we can't give up in the face of something difficult, that even when it's not going in the right direction. And also, the truth is, with suicide prevention, the lives that are saved are always going to be hard to capture and measure. And so we do this work with, in a way, a belief and a faith in science, in the public health model, and in relationships among families, communities, and organizations. And we've seen that be an incredibly powerful and potent combination to spark change. So, I mean, that's the way that I do need to continue to ground myself and kind of encourage myself to not give up. I don't feel like that it's the time to give up by any means. That would have been like, giving up on, coming up with a vaccine for coronavirus or, HIV AIDS, and look how mortality has diminished by about 20-fold over the last, decade or two. And that's because of advances, destigmatization, the science, but also culture and communities changing around that. So, obviously I really believe in all of this. I feel passionately about it. And then the self-care part is finding ways to keep my own little, my own micro little self and resilience just as strong as possible day to day. Again, I deserve that, number one, but I'm also a resource to my family, to my work, and so forth. So, again, that helps me. Maybe it's a little bit of a neurotic reason to have to frame it that way, but it helps me.
I don't know if it's neurotic. I mean, not that I get to judge, but I don't know if there's a neurotic reason. I think it's reminding yourself that you're a resource for so many of us, and that while it's, I'm sure at times a bit of a burden, especially with the job that you're in, we need you. And being of service is something I think for all of us, whether you're in healthcare or not, something that our human nervous system recognizes, something that lights us up, something that gives us a sense of meaning and purpose and human connection. So it makes, I don't think, whatever analyst told you it's neurotic, I don't know. I think it's being a human in a stressful and challenging job with a big task ahead of you.
Yeah, no, thanks, Drew. I appreciate that frame on it. And as you were saying that, I was thinking about, like, I believe that's true for every person. Like, that we all go through difficult times. We can even become so desperate or in pain that our brain goes there with suicidal thoughts. But for every person, there is a way, there's a path towards figuring out what is your sense of connection, your meaning, and your purpose. And we're very, very blessed if we can find it, and if we have a community of people or helpers, therapists, others that are in this journey with us. But I believe that for every person, and we all deserve that.
Well, the beautiful words. Christine, thank you so much. And everyone who's been with us for this episode, thank you. I hope there are a lot of very valuable takeaways. As always, this podcast is for you to make time to work on your mental health and improve your mental fitness. And suicide prevention is a part of that. It's a common experience many people have, especially if you're maybe depressed for the first time or have tragic news or get into a problem with a substance. And it's something that deserves your attention. As Dr. Moutier has explained to us, there are reasons for these feelings. There are things that can be done, ranging from communities moving upstream and understanding real modern science-based prevention tactics to individuals doing a good job. I love how you mentioned about the adolescents. Something about adolescent friendship. Our daughter's 13, so I'm seeing a lot of tween friendship. It's so it's got such fervor to it.
Yes.
like loyal friendships. And I think as we are adults, somehow, as we get busy with other things and families and relationships, right, that maybe some of that goes away. But I love this idea that, it's your job as a friend. It's your job. And you speak up, take care of your friends, because they're really one of the most precious assets that you have in this life.
It's so true. I mean, just simply checking in on each other, and I don't know. Our modern society has got us into some weird habits and spaces, but it's not. We can change that just by our own reflections and putting it into practice. And again, we're if you do find that kind of friend or friend group, you can actually talk about how important it is to do those kinds of things for each other. And it kind of helps keep it going too, when there's almost a celebration of like, wow, we're so lucky. And we show caring and unconditional love in these ways.
It's so wonderful. Everyone, in the show notes on website, ramseymd.com, will list all the resources, but the main one is the AFSP, which is the American Foundation for Suicide Prevention, which Dr. Christine Moutier, who we've been talking to, is the chief medical officer. She's been there for 10 years and helped so much change and happen. It's such a treat to hear your expertise, and thank you so much for taking time to share with our community, and thank you so much for everything you and your team do for our country. It's incredibly important we make progress on this, one of the top causes of death in some populations. And because of your work, we are. Everyone, please do what I always ask you to do. Take whatever nuggets are sticking with you and do something with them in your own life and in your community. I look forward to seeing you on the next episode. Dr. Moutier, thank you so much.
Thank you for having me. It's been a wonderful conversation.